I was just mentioning that you have used both Virion and Celestro.
Yes.
So you'll be able to tell us more as to what are the advantages of
Yes.
Virion over manual and what are the advantages of Celestro over Virion, or which is better, Virion or
I
Celestro?
understand, sir. So I have very little experience with Callisto, but I've used it in many live surgeries. But in my own clinic, I use the Virion, and I'll try to tell you cover up both these aspects which you are asked me to. So I'll
Yeah.
just try to help you with that. Thanks a lot. So let me just remove this. Okay. So in fact, I renamed my topic because I was given the topic Callisto. I requested Dr. Namrata that I don't have full experience with Callisto. So she said that you could cover what Dr. Sharath will leave aside, So
Okay.
I'll just go on.
That would be nice.
So
But
I think,
Sharath, please, you also give your inputs.
yeah,
Uh,
definitely, sir.
yeah.
So I think we all understand the limitations of manual marking. I've been doing it for years, Torics, maybe for more than 10, 15 years now. And of course, a huge amount of experience with the manual marking and last 7 years with the image guided systems. And so I think the limitations of manual marking are that accurate keratometry is the basis of all calculations, and accurate calculations and toric planning are even more important. So I think torics require you to be good with, first of all, capturing the right data from the keratometry, then interpreting it correctly, and then doing the planning correctly. And then after that, once you've done the planning and ordered the lens, then when marking, you should be able to mark it in the just outside the OT, where you would use the slit lamp or one of these devices like the oil-based marker, or you might want to use the I prefer to use a slit lamp when my Virion is down for an occasional day in the year. And however, we all understand that in the best of hands, an error of 5 to 10 degrees is entirely possible with whatever way of manual marking you're going to use. And then the marks may smudge, they may spread. You may not be able to get them absolutely on axis on both the meridians, which is at the 180 and the 90. And the final marking under the microscope is totally dependent on what you've marked manually. So if you have made any errors in the marking in the OPD or in the just outside the OT, they will get multiplied when you get transferred to the microscope, because that's what you're going to rely upon. And finally, if you have made errors at 2 or 3 points, and suppose you've made errors of just 2-3 degrees at each point, they will all get multiplied in several numbers. So I think what we all understand that. Now coming to the image guided system, we all understand the limitations, but yes, manual marking can be done, and those who don't have access to image guided should not feel small that they cannot execute it. It's just that they have to pay much more attention to detail than a person who has been using image guided systems. So I think we all understand that the Virion systems, as Dr. Sharad Babu showed, can be used for the registration. And let me just numb this. And the image guided systems helps us in several ways. It helps us with the rexus, incision placements. It helps us with the getting the perfect rexus. It also helps us with perfect placement of the lens. So I think I will not go into too many details, because we all know this and we have seen this ad nauseum. And my purpose today is to show you, a little beyond what, we all understand what image guided does. So going on to the lens implantation, I think we all understand that we can do a lens implantation quite nicely with the image guided systems. I use hydro implantation because for almost last 7, 8, 10 years that I don't use viscoelastic at all now. So again, another limitation of toric IOL placement is that if you leave visco behind the lens, it can rotate more easily. And it's very important to get the fluid out from behind the lens. And you can see how nicely the image guidance system will show you right till the end. Now, let's come to some of the fallacies that you might see with the image guided system and what we have done, what we can do to prevent that. So this was a small video, and you'll see that I've put small marks there. And I learned to put these marks because I realized that in some cases, 1 out of maybe 30, 40 cases, at the end of surgery, the image guidance starts showing you fallacious, markings. And that happens because of small, you may induce small hemorrhages, you may induce some chemosis. So the landmarks on the conjunctiva around the limbus may be lost. Even if you're doing a femto-assisted surgery, you may have small hemorrhages. And while you can see here that the image guidance is showing me the exact thing, but if you go right in the middle of the video here, you'll be able to appreciate that see now it's going off by almost 10 degrees. So you can see that the toric mark is off from the original marking. So essentially what can happen is that towards the end of surgery, your image guidance may, in a very, very rare case, malfunction. So I'll show you a safeguard that I follow now. Right at the time of surgery, I'll put these marks. Now you can see that these marks are going to smudge. So this is again about a 7 years old, 5 years old video. I no longer use the pens to mark it, but essentially when you do a registration, as soon as you're starting the surgery, at that time, if you can put a mark on where the thing is showing, that will be usually very, very accurate. And that will not change till the end of surgery, so that towards the end, you will not have a problem of the Virion or the Callisto systems, showing you a small error in their measurements because of the lost landmarks on the limbus. Going on, now, this was a recent video which I pulled out today. This is a pediatric cataract. So it shows subluxation, a little bit of zonular dehiscence, and we are now see this. I'm using a 26 gauge needle, using the thing to mark out the cornea after doing a registration. So essentially, we are using the virion for doing everything, the registration of the landmarks, the registration of the axis, but then I put check marks using a small 26 gauge needle, with the pen, and that helps me. Now you can see here that pediatric cataracts, of course, are a challenge by themselves, and this one was subluxated and very high astigmatism. And this young girl was about 8 or 9 years old, and I was wanting to correct almost 3.5 diopters of astigmatism with a toric lens, and then on top of that, this was a subluxated lens. So we managed to get the rexis, of course, which is, and you can see here that sometimes the if you're under very high zoom, these image guided systems will go wrong, and they will start to show you a small rexis right in the middle. They lose their landmarks on the limbus. Now here, of course, let me go towards the point. This patient, we put a CTR. So toric IOLs, I think very, very important message is, if you have the slightest of zonular dehiscence, if you have a choroidal coloboma with a lens coloboma, please, if you're putting, and these are the eyes which are likely to have high astigmatism, it's very, very useful to put in a CTR to ensure that your bag remains distended and the toric IOL will not get malpositioned when you leave it at the end of surgery. Otherwise, sometimes it will get malpositioned. So if you have a small zonular dehiscence or some kind of a situation where the bag is not perfectly healthy, please put in a CTR. So here you can see, now here I like to pause it. I've completed the placement of the toric IOL. I've done a hydroimplantation with a CTR. Now I'm not going to take out my infusion from the left hand. So my hydroimplantation was done. My chamber is always going to be formed completely throughout the procedure. And with the chamber formed, I'm hydrating my wounds. So there is no fluctuation in the chamber which can have the toric IOL rotate inside. So this is another thing which really helps. You can see here now I've hydrated the side port. My infusion is on, my chamber is absolutely formed. And now I'm hydrating the main port. So now my 2 ports are hydrated. And now my 3rd port, immediately on withdrawing that infusion, I'm going to infuse that also and seal it. So this ensures that there is no rotation of the toric IOL, and there is always, and this is my technique of putting trypan blue to check for any leaks. And I do this for all pediatric cataracts or even with adults cataracts where there is a possibility of a wound leakage, because this ensures that if you see a small stream of fluid, as you can see on this spot, you can then go and hydrate it again. It's very simple and it works very effectively. I've been using it again for many years, and intracameral moxie, and then checking the pressure of the eye with the finger, as Dr. Blumenthal used to do. So these are few of the pearls. Now at the end of surgery, it's very important not to overinflate the eye as well, because one of the commonest causes of misalignment is basically from overinflation of the bag, and the toric IOL can rotate within the first few hours of surgery. That's the most common time when it will rotate. Another patient where we are putting in a toric IOL again with hydroimplantation and with the small marks, as you can see, those are my check marks, and then you can complete the surgery by rotating the lens. Now here I wanted to showcase something else. We have done the marks, we've done everything right. In a busy OT, sometimes, if you have a smallish pupil, you may not see the toric marks, and at the end of surgery, you started off thinking you're doing a toric. In this one patient, I could find when I forgot that I was supposed to do a toric. I hydrated the wound. I did not position the lens. So please be very careful. I have now trained my staff. This one instance trained me that when they hand over the lens to me, they just speak out loudly, "Sir, toric IOL." Because in this one patient out of about 700-800 torics that I've done, I closed the eye and I did not rotate the lens into place. As soon as I removed the patch and removed the patient's drapes, I suddenly remembered that I had forgotten to rotate the lens. So we went back, cleaned it, and we were able to save the day. But this can be a big disaster if you have not rotated your lens into place and close the eye, and you may forget. So this is one last. Now I'll just go to my last slides. I'll bypass these 2 videos just to compare the image guided system versus manual marking. And I'll show you my own data also. This was a recent study which has compared the 2 things. And this was basically done comparing using the Virion system in Maastricht. And the conclusion was that the IOL misalignment was significantly less with digital marking than with manual marking. And this did not result in a better, uncorrected distance visual acuity or lower residual refractive astigmatism. However, there was a very significant difference in the 2 systems. In our own hands, what we now do is at 2 weeks post-op, when the patient comes in for their final refractions, we do an eye trace to check all patients for their IOL positioning. And you can see that the eye trace has a very good toric check system. It will tell you what is the position of your lens. It will tell you what is your corneal astigmatism. And you can see if it is suggesting any misrotation or any, correction to correct for this thing. Now this is eye trace, but you can always do it manually also, and you can just put a drop of dilator and see the patient on the slit lamp, and you will be able to immediately see whether your IOL positioning is correct or not. Please do this for all your patients in the first post-op day and also at the 15th day, because that's the time. After that, usually the rotation will not happen except in a very, very rare case. Our own, last slide, our own experience, we compared 100 eyes. What we did was we marked them manually outside the OT, and then we did the Virion registration as well. So a patient was marked outside and then patient was taken inside, and we had already done the Virion for that patient. So then we did a Virion registration, and we found that there was an average of 4.32 degrees error in the manual marking system compared to the Virion system. So this was again significant. And the maximum we found in one patient was 14 degrees, which means that what mark we had put outside was off by almost 14 degrees from what was the actual marking on the Virion system for the exact placement of the toric IOL. Also, another small data which I would like to share. Post-op rotation, we did a retrospective analysis of 3 months, at 3 months post-op of 50 eyes in each group, the manual group and the Virion group. And on the manual marking, we found an error of about 6.19 degrees average, whereas in the image guided, we found an error of 3.98. So while both showed some error, but definitely the error was more with the manual system than with the Virion guided. So to conclude, I think image guided systems for toric IOLs, for those practices which are doing significant numbers or want to do significant numbers of toric IOLs, it's the way to go. It minimizes errors at every point, which means that when you capture the data, when you do the calculations and the planning and ordering the lens, and to the execution, it helps at every point. It is also much more ergonomic. There are times when I have in one OT about 7 or 8 torics, and I would not want to go back and mark out each patient because the marks will dissipate, or they will get erased by the time. So it really saves a lot of time, and you can actually do your surgeries much, much faster and better. And our toric numbers went up from just about 5% of our total practice to almost 23% over the last 7 years that we've been doing the image guided surgeries. And with that, I think I should stop. Thank you so much.